Brownbag. We are extremely honored to have Dr. Poudel-Tandukar, and I think I mangled your name, so you're going to correct it for me, who is an associate professor at the Elaine Marieb College of Nursing at the University of Massachusetts, Amherst. She has a broad background in international health, epidemiology, social science, and general medicine, with training in community-based participatory research, intervention design, and longitudinal data analysis. She has over 15 years of experiencing researching global mental health, HIV, and nutrition. She's interested in applied and translational research on developing and testing culturally tailored, community-driven, strength-based interventions to reduce mental health disparities among refugees, immigrants, and HIV-infected populations using mixed method approaches. She's also the PI on an NIH-funded research project evaluating the effectiveness of a preventive intervention to reduce stress and mental health problems among immigrants using a randomized control design. And she's received grants to implement social and emotional well-being interventions for the Bhutanese community, as well as the Ukrainian and Afghan community members. And she has received a grant from the Massachusetts Department of Public Health to implement healthy aging interventions among older adult immigrants in Massachusetts. I can't think of someone who has more experience to speak to us about the issues that we're always talking about here in our community of Clarkston, Georgia. So welcome. Thank you so much for being here. I did not introduce myself. I'm Mary Helen O'Connor, and I'm the Deputy Director of the Prevention Research Center. And so I'm honored that you were able to make the time to join us to talk about your work today. We have so much to learn from you, and I think we can go ahead and get started on your presentation.
Good morning. Thank you so much, Dr. Corner, for your warm introduction. I'm so much glad to be here today. So can I share my screen?
Yes, you can.
So I hope that everybody can see my screen right now, right?
Yes, it looks great. Here we go.
Okay. So thank you so much for this great opportunity to present my work today. So I'm so much glad to be here to present our study entitled Reducing Stress, Anxiety, and Depressive Symptoms by a Family-Centered Preventative Intervention for Immigrants, a randomized controlled trial funded by National Institute of Mental Health. So today I would like to focus my talk on community-engaged participatory action research to assess the need, plan, implement, evaluate, and disseminate the program outcome process. So why I was interested working in the immigrants? It's like stress is common in all human beings. However, the stress might be more among immigrants due to their traumatic and everyday stresses during and after migration, which may contribute to the high burden of mental health problems among them. And stress resulting from attempts to integrate into a new culture takes a heavy toll on their mental health due to their limited language and other sociocultural skills. And immigrants living in the United States are more vulnerable to depression, anxiety, and psychological distress than the general population. And although the mental health treatments are available, immigrants highly underutilize such services. And moreover, the existing mental health interventions are largely based on the treatment models to improve the access and quality of care for those with diagnosed mental health problems. Thus, we are so much interested to develop the preventive intervention that aims to reduce stress among immigrants. So in broadly, we have three broad aims of our research project. The first one is to identify the sociocultural and behavioral protective factors that reduce risk of stress and mental health problems among immigrants and refugees. And our aim too is to develop a strength-based stress management intervention using community-engaged participatory research approach. And our last aim is to test the effect of stress management intervention in reducing stress and improving mental health outcomes. So before starting this, like as a first step, we are somewhat interested, and we are interested to work with the Bhutanese community members because of three main reasons. The first one is the Bhutanese people are one of the largest group of recently settled South Asian immigrants in the United States. And about 100,000 Bhutanese adults have been resettled in the different states of US since 2018. And according to the CDC survey, the mental health burden is quite high among them. And as a matter of coincidence, I worked with them as a clinician in Nepal during their emergency resettlement in 1992 and 93. And I share the same Nepali language and culture that they do. So I feel like that I'm in a better position to understand their cultural dynamics. So to design our current problem management plus intervention for the immigrants, we conducted series of preliminary studies to identify the social and emotional stressors and protective factors. And based on that, we explore culturally tailored program components to design an intervention, and we pilot tested an intervention in a small group and family settings. And now we are replicating an intervention, preventative intervention in a large community through NIS support. And today I wanted to discuss briefly the community engagement process that we have undertaken in each project step. So as a first step, we conducted a series of meetings with the community leaders and members and identified mental health problems as one of their priority health problems. And as a second step, we trained selected members from the community as a community resource assistants in conducting focus group discussions. And community resource assistants selected the participants, facilitated focus group discussion, took notes and transcribed and documented findings of each focus group discussion conducted among 64 participants. And as a third step, we selected another group of community members as a community resource assistants in conducting quantitative and dietary surveys, hair sample collection, anthropometric, and blood pressure measurements. And those trained community resource assistants, they selected the participants, conducted surveys, and collected information on various mental health outcomes, protective behaviors, and 24-hour dietary behaviors from 226 participants. And we identified several social determinants of health and measure an association of sociocultural protective factors, micronutrient intake, and stress biomarker to stress, anxiety, and depression. And our cross-sectional study shows that we found the mental health burden was relatively high in this population that is presented in the table 1. And our another qualitative study also showed that the community members were quite optimistic and they are interested in learning new skills required to adjust to the new sociocultural environment of the United States. And another study showed that the higher resilience was associated with the reduced anxiety and depression among Bhutanese, and with personal competence, resilience accounted for most of the effect, and the detailed results are presented in the table 2. And regarding coping, we found that the greater use of problem or emotion-focused engagement coping style was associated with the reduce among Bhutanese. And we share all those study findings with the community members, and together we explore the different culturally preferred intervention components, such as stress management, coping skills, and cross-cultural communication skills to address their social and emotional needs by incorporating their strengths. And finally, we related these intervention components to the evidence-based mental health intervention, such as psychoeducation, problem solving, and mind-body interventions. And we included them in designing our social and emotional well-being intervention. So we trained selected community members as a community interventionist to deliver the intervention in family settings. And those trained community interventionists implemented 2-hour session each week for 5 weeks. And the first hour of each session included a brief health education lesson and a small group exercises identifying at least 3 problem-solving approaches and making weekly plan to practice them. And in the second hour, participants enjoyed breathing and mind-body relaxation exercises, and educational materials were provided to all the participants that content cover culturally tailored tips for stress management, strengthening coping, communication, and social networking skills, and pictographs on breathing and mind-body relaxation exercises. And participants were also encouraged to practice problem solving, breathing, and mind-body relaxation exercise with their family members. And our pilot intervention showed that the prevalence of anxiety and depression reduced from pre to post intervention by more than 50%. And this is the small pilot test study with pre-post intervention design only with 103 participants. And our results also show that the protective measures such as coping, social support, and social networking dramatically improve from pre to post intervention. And by incorporating all these successful results of the preliminary studies, we advance and scale up our intervention at the problem management plus intervention for immigrants on a larger scale with NIH support. And this PMPI is a family-based preventative intervention that aims to reduce the stress, anxiety, and depression. It has 4 broad components: psychoeducation and stress management, and mind-body intervention, problem solving, behavioral activation, social support, and social networking. And community interventionists deliver 5 sessions, 1 session per week at family settings together with family members. And this is our study flow chart. So we use a screening tool to exclude the individuals with depressive symptoms as we aim to evaluate an intervention effects to prevent the depression. So we include Woodney's adults 18 years or older resettled in Massachusetts with a score of 14 or below on patient health questionnaire as a screening tool to include the participants. And the eligible participants were randomly allocated to the intervention and the control groups with 58 families in each group after the baseline survey. And the intervention group received a 5 session of PMPI intervention, and the control group received a talk program. Then they were followed up at the post-intervention and 3-month post-intervention. To implement the program, we train 3 groups of community members to deliver an intervention in the family settings. First is a community interventionist. We train selected members from the community as a community interventionist, following the World Health Organization training manual for 10 full days. And for the community resource assistants, we provided 2 full days of training to the already trained resource assistant in the recruitment, informed consent, confidentiality, survey procedure, questionnaire orientation, hair sample collection, blood pressure measurement, and the anthropometric measurements. And we train 2 members of the community as a community field supervisor, following the World Health Organization training manual for 10 full days of intervention and 2 more additional days for the supervision. And so we recruited 116 families in year 1, like 20, year 2, 80, and year 3, 16. And from each families, we recruited 2 adult participants for the survey purpose, but all the family members are welcome to join the intervention. And for the program delivery approach, the community interventionists, they deliver 5 sessions of intervention to the participants and their families. And the community resource assistant, they conduct a survey at the 3 points, like before, after, and 3 months after intervention. And the community field supervisor, they supervise the field staff conducting surveys and delivering the interventions. And we use different validated scales to measure our primary and secondary outcomes. Our primary outcomes are stress, anxiety, and depressive symptoms. And the secondary outcomes are family conflict resolution, coping, self-efficacy, social support, and family satisfactions. And we measure hair cortisol at the baseline and the 3-month post-intervention. And we fully engaged community members in the process evaluation to mentor their colleagues each week after the session as peer supervisor and field supervisor. And they collected wide variety of information for the intervention fidelity measurement by using checklists and short questions. And our PMP program is guided by the Lazarus and Folkman's stress and coping theory and Bandura's self-efficacy and social cognitive theories. So guided by this theoretical construct, our PMPI program aims to reduce stress, anxiety, and depression by improving individuals' coping, self-efficacy, social support, family conflict resolution, family satisfaction, and social networks. And indirectly by and these are the important target mechanism to improve the mental health outcomes. So at present, we have completed data collection for all these outcomes from 100% of all the participants. Now, currently, we are analyzing data to measure the effect of intervention directly on the primary outcomes and indirectly through the targets. So that's why today I don't have any data for the outcome of this project because we are in the analysis stage. And finally, then I would like to thank all of my collaborators from the various disciplines for their support to implement this project. And I'm so much appreciative and thankful to all the community leaders and the members from the Buddhist community to complete and to conduct this study. And thank you so much. So I would like to talk more about the different questions about the community engagement process that we have been doing to come up with this project.
I think that would be great. And everyone on the call, please feel free to post questions in the chat. I'm really excited because we are in the process of considering using PM Plus here in our community. And so I have a lot of questions and I'll go ahead and get started. And I wanted to hear, first of all, how your implementation worked with that particular, I'm intrigued that you all approached families to participate instead of just an individual intervention. And I wondered if you could talk a little bit about that. Seems like a really effective way, especially in communities where mental health interventions are kind of new or they're not accustomed to. So I would love to hear you talk a little bit about the recruitment of families and the implementation of PM Plus in your work.
Yeah, thank you so much for this great question. Yeah, this is the series of work we have started from 2015. Just I presented very briefly on how did we come up with this intervention. So as a first, we worked with the community and we started with our first intervention was in a group setting. We developed by one small scale social and emotional well-being intervention as a first step. And we conducted that intervention in a group setting first. And we found the huge impact of that intervention in the group setting. And after that, we talked and we presented our findings with the community leaders. And then they're really interested that why don't we implement this program in the family settings? And to implement the program in the family settings is not easy, right? Because for the hiring and recruiting, all those things, and then language things, all those things. And then we worked together and we came up with ideas to select like 10 members from those who attended our first group intervention. And we selected 10 members from those who already attended our first group of intervention, and we trained them as a community interventionist. And then we let them recruit like 10 participants. Each member can recruit at least 5 to 10 participants. And that's how we deliver our intervention in the family settings. And with the result, we found that the family members were so much benefited by the intervention, and not only for the benefit, even to get the support from each other. Also, if they do program work together in the families, then they get lots of support. And that is so much exciting, not only for the participants, but for the whole family to work on their stress, because stress is so much related not only to the individual in the family settings, especially in the South Asian in Bhutanese community. They have a strong family connection and they really work together for each other's family problems and all those things. And they really like that family settings and they enjoyed working together with the family members on the programs. And we received lots of feedback, just like even the small children, school-going children also, they were so much interested to involve in the problem-solving approaches, to do the exercises by seeing all those pictographs. And we also gave them lots of tips. so that they can select some of the dish what them that might be relevant for them, so that they can practice at least once or twice. So by doing that type of approaches, all the family members, they were so much excited and pick up one team so that they can work together and talk about that. And small, even the school going high schooler children also, they were so much engaged in the process, even though they were not participants, but they were so much engaging their family members and their adult members in the family. And even just for the language one, we just gave them one simple exercise by saying that, why don't you start talking with your grandkids? Just try to speak at 4 or 5 English words each day, so that you'll be able to communicate more with your grandkids in further language, and you'll be able to interact more with them in English. And that one also they found so much interesting. It looks so small, but they tried their best to speak at least 3, 2, 3, 4, however the number of the new words they can speak. And those are the small things that we included in our intervention, and that one was quite effective in our pilot test. And through that approach, and we are so much encouraged to implement the intervention in the family settings. And when going to the family setting is based in our pilot test, all the members, they want to be in the program, right? They are so much excited. And we cannot recruit all because of all the different financial things and all the measurement process. And after that, we decided that, yeah, all are welcome to join the intervention, because this is the family-based intervention. That is the benefit for all. But we decided to recruit only 2 as a main participants, so that we can measure all this survey process for the 2 participants, but all the family members, they can join. And in terms of the like to find out how many members they join the intervention, we developed different observation sheets so that we can monitor how many family members they join the intervention in each session. But we did not like survey measurement. We did not do for all the participants, only for the main primary outcomes. But we have all this record for how many participants joined the intervention. That type of information we have, and that's how we decided to design this intervention by implementing in the family settings with involvement of all the family members, but the main assessment is only for the 2 adults.
So the PM Plus model it's a very intensive training. It's a lot. So you took 10 community members and they got the full PM Plus training. And I'm wondering, they all had to be bilingual. So did you do the training in English?
Yeah, this is the very good question, right? So those trained community interventionists, they are going to different colleges right now. That's why they are fluent in Nepali and English, both languages. They are Bhutanese community members,
Yeah.
and they can speak both languages. And then we invited them in our college because they really want to be here to learn because if they come out from their community, then that will be the different mindset. So we invited all them to our UMass Amherst for the 12 days. Especially we invited them in the weekends, like Saturday and Sunday whole weekends. And then like 12 days, 10 days for the intervention and 2 days for the supervision. So we conducted 12 full days training for the 12 community members, 10 as a community interventionist and 2 as a field supervisors. And one thing noticed that the process, we hired them as a part-time employee of UMass Amherst, because we have to pay them, right? Because so if we have to pay more than $100, then we have to recruit them in our system. So we recruited them in our system by going through all the hiring process, background checking, and then all those things. And then we hired them as a part-time employee of UMass Amherst. And after that, we started all these trainings because they are still working with us for many years. And then, so by doing that, then we conducted full training, and they can speak both English and Nepali language. And then in the community settings, we fully conducted our program in the Nepali language, because not everybody, they are fluent in English. So basically we deliver all the program in English. And for the training also, we use mixed languages, because sometimes we use English and sometimes we use Nepali. And especially for the case scenario and observation and the role plays one, basically we did in Nepali. And we are using like mixed language, but all the community members, they were fluent in English and Nepali language.
Wow. So I'm going to look at the chat and double up some questions. We have a question about which acculturation scale did you use in your study? And I'm wondering, whenever you use either the screener or an acculturation tool, did you have it translated into Nepali? How did you administer those instruments?
Oh, yeah. So for the questionnaire, we develop both in Nepali and the English language because in the community, some community members, they can speak Nepali, but they cannot read. Like that's the problem because of different generation of the people they are migrated here because of different changes in the age background because we recruited all 18 plus, so our age group is wide range, so we develop questionnaire in both languages. And so whichever the questionnaire they feel comfortable, they used to take the questionnaire and they do the self-administer questionnaire. They fill up the questionnaire by themselves, and when they need help, the community resource assistant, they explain the meaning of, they read the questionnaire if they need, or they need some explanation, then they were there to explain the meaning of the questionnaire for each skills. And then we use all those skills that has been used in the Buddhist community and as well as in the other immigrants. Because even for the Buddhist community, I did different pilot studies. At that time also, I used all those skills to measure those coping, social support, family conflict resolutions, networking. Those are the different measures we used. And we use actually both language to collect the information.
So I'm wondering if you were gonna give us advice as we start to think about implementing this program in our community. It will not be just with one language. It's going to be with the community here. There are over 60 languages spoken, but I wondered if you had any advice for researchers, especially in this space, who are always having to figure out how to do important research work in communities where literacy and language are so diverse. If you, as just a researcher, had just guidance and wisdom that you could share with all of us about all of this incredible work that you've been doing and what you've learned.
Yeah. So in my case, like if we have a specific group of the language, then it is possible to recruit those members who can speak the language, right? But if you said that you have participants who speak more than 60 different languages, then it's so much challenging to recruit the participants from different language background. So in my case, if I were you, then it is very difficult to recruit the participants with all those different language backgrounds. So in that case, my first step will be to recruit participants who can speak English also, because otherwise it is hard to find the 60 different languages. So I first step will be to recruit the participant who can English, who can understand English. And that might be the first point, to reach out to the participants who can speak 60 different languages. That might be the first step to reach out those wide audience.
So we have another question in the Q&A, and this person was asking, how did you control for contamination within the community?
Yeah. Okay, thank you so much for that great question. So for that one also, when we inform the participants by saying that, yeah, you will have the 5 different sessions of intervention, because for the control group also, we had a 5 series of talk program, because in the community, we cannot leave the community as it is without giving any intervention. And even just our visit also, it gives lots of differences when we measure the outcome. So to minimize all those contamination, we made 5 visits to the intervention and 5 visits to the control group, like same amount of visit to the participants. That is the first way we control the contamination. And the second one is, when we recruited the participants, at that time, we told them that we will have 5 sessions of interventions. Not which one, 5 sessions of interventions. And even after the program also, if we need to tell, if we miss something, then we will give you again the missed part of the interventions to you. In that way, we deliver our intervention. And even for the intervention group also, once they completed their 3-month post-intervention, we again gave them 2 series of PMPI intervention to the control group as well. And we recruited community interventionists from the different areas of Western Massachusetts, and we randomly collected for the intervention and the control group. That's why the participants, they were in the different settings, like, so that they were not aware of they were not having interaction with the intervention and the control group participants, because they were widely scattered all over the places.
So did you use different intervention strategies for all of your family-based sessions?
For the PMPI intervention?
That's just one intervention, but in any of your other projects, have you used other family interventions?
Yeah, for our pilot test intervention about the small scale one, we designed the social and emotional intervention like a small scale intervention, but our approach was same and we didn't have control because of the financial issues. We just had a pre and post intervention for the pilot test, and approach was same. Like we trained the interventionists and they went to the community and they implemented the 5 sessions of intervention. But all those pilot studies, we didn't have control group, but the approach was same.
So I'm kind of laughing a little bit inside because we recently had some Afghan students relocate to Western Massachusetts, and I know that that's actually they're not a lot of immigrants that live in Western Massachusetts, but it doesn't seem like you had any trouble recruiting participants for your study. So is there a fairly large Bhutanese community in Western Mass? And I know you've been working also with the Afghan and Ukrainian communities. So I wondered if you could talk a little bit more broadly about resettlement and immigrants in Massachusetts.
Yeah. So in the Massachusetts, we do have immigrants and refugees from very different background. We have immigrants from all over the places. And in my case, first I started working Bhutanese because of my cultural similarity and language and all those things. And then I was also new. I came to US only in 2015, and I started my new project here. And that one was my entry point to work here. And after that, for the Ukraine and Afghan refugees, like we had students in our School of Public Health and Health Science, like students from like Afghan and Ukrainian community. And then we mobilize those students to reach out to the community members in the community settings. And for that, to recruit the Afghan and Ukraine community members, we collaborated with one organization who is working with those refugee resettlement areas. And we engage our students to work with them because we need to develop all the tools in their language and we need to interact it with them. And we used our own public health students to work with that community, like we hire Afghan and Ukrainian public health students, and they help us to develop all the tools, intervention materials, and even they were with us to implement the intervention, to interpret all our conversation and the findings. And we collaborate organization here to reach out to those Ukrainian and Afghan refugees, like students and organizations, we work together.
We do the same thing. And actually, some of those students are listening to this call. So I'd like to think about if we put on a different role us as professors. And I think if you have any kind of words of wisdom or encouragement for some of our MPH and undergraduate public health students who are on this call, who are actually people who have the experience of forced migration and have been refugees. They are people that I'm super excited to have in our program. And so I'm wondering if you have some tips or suggestions for them professionally so that they could be engaged in these kinds of projects, and what kinds of things should they be looking for to advance their careers in public health?
Yeah. Yeah, for the student, in our UMass Amherst, the students are so much interested to involve in this type of project. So we are engaging students in a different way. Just for the undergraduate students, we are engaging them in the data collection, like a data entry and data management, so that they can learn all those tool development process and how the data were entered. And after that, once the data, how we are going to visualize all those data in the paper. That one they found quite interesting because I have been working with so many undergrad students for the data management work. They enter and then they analyze and then they see the whole picture of data, right? Oh, this is the way first we started to develop the tool. And once we collect the tool, then we can present the data in this way. And it has a great meaning to design the intervention. Undergraduate students are engaging in our project in this way. And for the graduate student, like recently we needed to do the external evaluation of our project, like how the community members, they are feeling working with us, with the university members. And that one is for the Department of Public Health grant. And for that one, what we did is we hired the graduate student and she did like independent project, right? She is working with us to do the interviews with all of our community leaders and members to know how they are feeling working with the community members and what was their satisfaction, what did they find that was helpful for them. We had a different question. And then we worked together, and she is interviewing all our community leaders and participants, and she is analyzing data. She is going to develop the report, but that will be her independent project, and she will get credit for that. So it has like she will get the credit also at the same time she's learning all the research tools, and she's also engaging in the research process. That's how we are working with the undergraduate and graduate student. There are so many different ways to engage the student in this process, and especially that we really need the help of bilingual student so that we can work. That's the good thing. So we really need bilingual student, and it is a so much good opportunity for our student to work in this type of project so they can largely contribute in terms from the very beginning to design the tool, to then to develop the intervention manual, to deliver the intervention, to collect the data, and even to interpret the data. Because when we go back to the community to present our data, we need their help, right? They are in a so good position to connect us with the community members because they know the science and they know the community also. So they are the so good resource for us to work with the community members, and even for the students also. It is a so good learning point for them, so that they can engage with their community members and giving them back something from the scientific point of view for their applicability in the daily settings. So we are working with a large group of undergraduate and graduate students in that way.
There are actually some students on this call that I use the same way. They do quite a lot of translation and interpretation for me. They're probably tired of me asking them all the time to help. And we ask our students to help us a lot with cultural understanding and sharing so that people can learn from the community themselves. And I admire all of the work that you've done from within the community. I'm wondering if you could share just a tiny bit, if you know, how is the community feeling about the work that they do with the university? Are they feeling encouraged, supported, interested?
Yeah, I have lots of information on this also because today I needed to finish in 1 hour. That's why I made my presentation very short. And regarding student also, I just wanted to add one thing. After that, I'll come back to this point for the student. If they can do the independent project, that is a huge like a credit for them also, so that they can get credit for their work, right? That's the thing. And in our case, like we encourage students to do the independent credit as well as honors thesis. So my other advisor, they are also doing honors thesis by using the data. They used to work on the part of the data and they write their thesis. So in that way also they can engage in our research project, even though they are not bilingual. Because I'm
Yeah.
giving opportunity to non-bilingual student also by letting them do the honors thesis if they are interested working in this field. So yeah, that's the one. Another one, but in terms of community members, I have lots of stories on that and how they are feeling. So the one point I really wanted to highlight is that I still remember that when I had an interaction with the community member, they said that after coming to US, they said that they have everything. When they are sick, they can go to the hospital, they don't need to pay, and they have lots of counseling, all those education, everything. But their main concern is they don't want to be sick. They don't want to go to the hospital.
I
And that was
know,
the
yeah.
question that intrigued me to work in the prevention. They said that, yeah, we have everything here. It's not like in Bhutan and Nepal, but here, once we are sick, we have everything. But main point is we don't want to be sick. So could you please let us know what we can do so that we will not be the sick? We don't need to go to the hospital. And that's how I started my work in the prevention science. And in
Ah,
terms of their satisfaction, they are so much happy to take responsibility to work for the community. If only if we go and implement the program, they don't know what's going on there. But in our program, we are working with them from the day one in all the process, and even we are publishing all the papers by involving them in the manuscript. So in all of our publication, the community members are also the co-author, and they are contributing a lot in terms of interpreting the data. What is the meaning of data for them? So that
I
is the
that
use.
I love that, and I love especially my students and community members and including them in the manuscript
Yes.
process and making sure that they get credit for what
Yes.
they've contributed. Yeah, that's just so, I'm so glad that you highlighted that. I want to make sure we get the questions answered from the Q&A. So we had a question about is homelessness a problem in the community? That's one part of the question. And the other one is, what types of mental health challenges do you commonly observe? I think we also ask these questions a lot, like, are we seeing more depression or is it more anxiety? Is there, what is the most prevalent mental health challenge you see in your refugee and immigrant communities?
Okay. Yeah, so in terms of mental health problems, then I can see the anxiety and depression is very high that I presented in my data also. That is the
Yep.
finding of our quantitative studies, more than 30%, I think, as far as I remember. So depression and anxiety is so high, not only in Bhutanese, in Ukrainian and Afghan community members also, we found a very high prevalence of anxiety and depression, more than 25%, as far as I remember, more than 25%. And in the Buddhist community, we also find very high prevalence of suicidal ideation also. That is the finding we
I
find.
that's real actually very, I have a colleague who did a study here in Atlanta, but it was a number of years ago. There was actually, we had a serious concentration of suicides in the Bhutanese community, and it became his master's thesis. The Bhutanese community here has been here a long time, so I'm not sure, the Afghan and the Ukrainian communities are much newer, but I don't know in Massachusetts if the Bhutanese community has been there as long as it has been here. But that actually did come up a lot in the research and the mental health concerns in our community as well. That's very interesting to hear that.
And
Uh,
yeah, for that point, like we got a chance to talk with the community members back about the suicidal ideation. And what's the difference is that in the Buddhist community, it is so common to say that, oh, I want to die, right? It's not from their heart. Like sometimes whenever they feel that, oh, I just want to die, that is so common in that culture. It doesn't mean that the person is taking from their heart. I feel like it's quite a little bit different than white community. In that
Yep.
community, it's so common, like it's not their intention, it's like their cultural way of telling is so common. So that might be the reason of having high suicidal ideation in Buddhist community, because of cultural differences of taking that point. And that was the feedback I received from the Buddhist community leaders and members. Actually, we used to say, but that doesn't mean that we want to do that, because we are so used to saying that type of thing. So that might be reason for that one. But in terms of anxiety and depression, is quite high because of lots of different stressors they are facing, like working, studying, taking care of parents, and managing so many things. That's why anxiety and depression is so much high in
I
this
think
population.
we've experienced that that the levels of anxiety and stress tend to be worse after migration. So becoming a part of a new community seems to be more stressful in the research and the data that we've collected than actually being in the process of migration. So it's very difficult. And I think especially among older adults, young people are more easily able to learn a language and a new culture. But for the older community members, it seems to be more difficult. There was another question in the chat. Did you observe bias while delivering family conflicts and family satisfaction outcomes in a family-based setting? So it's a question about bias in the family, delivering in a family setting.
Yeah, for that one, in terms of result, I'm still analyzing the data. What is the relationship between those outcomes to the outcomes? That's why still I cannot say concretely on what is the result. For that
Yeah.
outcome, we are
Well,
currently.
we'll have you back. So just let us know when you're done, and then we want you to come back and tell us.
Yeah, we are analyzing the data right now. And for the family conflict resolution, how did we include our intervention component? Now, intervention is the problem solving. We have one broad component of the problem solving, and we let participants to come up with at least 3 different type of problems, what they are facing, any type of problem. And then we let them prioritize at least one on which they want to work by themselves. And then we work together to make them the plan, and they have to implement that plan in the following week to see how it's going on, what's the impact, or how it is going on. And next week, again, we visited them and we take their feedback and we again guide them to move forward to work on their problem. That's how we work in the family conflict resolution component in that way. And basically, we found like different type of problems, especially that generation gap, like older grandparents, they were not having not able to get communication with their grandkids, and they were not having time to have more interaction with the family members. That is also creating different type of conflict in the family, that type of conflict. For that one, we use different approaches to minimize by doing like the mind body exercises, breathing exercises, and then stress management tips and social support and communication network. All those tips we are using like a multi-sectoral, multi-integrated intervention component to address those all those complicated like a complex stress. That one. And then for the satisfaction, I really wanted to add one thing is that when we went to the community in 2015, like I see the community members, they were very different. And being ourselves from the nursing school and from the public health, we were also highlighting the importance of education, what they can do after coming here. They have lots of opportunities. They just need to move on for this study. So we were advocating study also from the very beginning. So at this time, from 2015 up to 2024 right now, I'm so much glad to tell you that currently those 4 young girls from the community, they are doing nursing study right now, who are working with us in our project. And one already completed RN, and
Oh,
one is
wow.
doing, yeah, and one is doing PhD, and one is doing MPS in Brown University. So this
Oh
is
my
like a
goodness.
big outcome
Oh,
I
that's
can
like,
see.
doesn't that just make you
Yeah,
so?
so happy being myself as a working as an academician, because that is not our direct intervention, like indirect intervention, but you can do it. Why not? I'm here to help you, whatever the help you need. And we were with them because the day zero, the none of them they have started this program, right? And then they have started working with us and they know all this process and they were fully engaged in all this research, publication, presentation, all the things. And this is the good thing I really wanted to highlight in all the topics. And now they are becoming role model in their community by becoming themselves as a nurse, as a public health, and doing PhD. And that is also bringing huge change in the community by giving them like accountability and responsibility. And this is also bringing sustainability because now they are already trained, and the other community members also, they feel like, oh, we have now somebody in our community, if we have some question to ask, they feel like that type of strong support and with whom they can speak in their own languages. And this trained community intervention is also, they are feeling much more proud now, because even in other time also they were invited by community member by say, oh, could you please come and help? Could you please guide me in this one? And they are feeling so much valued and having different self-esteem. And they are really enjoying this work and helping the community members even after the project. And especially those field supervisors, they are the community health worker also, and they are the pastors also. So they are doing lots of community work in their community. And then that is also bringing huge chance to make the program sustainable. So even after the project also, they are continuing this project based on the need of the community. And they are integrating all these program components in their women's group program and in their youth group program, because they organize different women's group, youth group, family visit program. So they are integrating all these long components of the intervention in their other program component as well, even though it has not been measured scientifically, but that is bringing huge impact in the community.
That's amazing. So I
Yeah.
love that. It's my favorite part of the work that we do.
Yeah.
This is a strange, not strange question, but so this work has been over such a long period of time. How was your research study impacted by the pandemic?
Oh, yeah. That one was, I got the grant actually in 2020.
Mm.
And yeah, that one that had a big pandemic at that time. So I could not start my project for 1 year because mine was fully based in the community. I need to recruit the community members, train the members, and they need to visit the family. So we didn't start the project up to 1 year. We just holded the project. And after that pandemic was little bit phased out, when it was okay to go to the community, then we started recruiting participants, like a community interventionist. And at that time, we completed our like a big training, those 12 days training. Immediately after that, when we were able to open to go to the community. And after that, we started our recruitment only when we are allowed to visit the families by filling marks and all those preventive measures. But according to the guidelines of Massachusetts, when we were able to visit to the community by wearing masks and all those things, then only we started recruitment at that time. And at that time, we have the university has developed all the checklist. And once you have symptoms and all those things, we cannot visit. And if the participants also, if they have those things, then we strictly maintain that screening criteria and wearing masks and all those things. And if the participants are sick, then we didn't collect any information. We didn't recruit any participants for 1 month. And that's why we took so long time to recruit the participants. It was
So
very
yeah,
challenging. Yeah.
you actually had to delay your whole project by
Yes.
a
For
year.
1 year, 1.5 years.
And was
Yeah.
so it was NIH funded, correct?
Yes.
And
Yeah.
was NIH okay with that? Did you say we can't start because it's a home visiting
Yeah.
program?
Yeah, because NIH is so much flexible, so much supportive. They understand the value and meaning of what we are doing.
Good.
And we need to like inform them by saying, this is my present situation. That's why I really want to have like since about this time, then they are so much supportive, especially for the community engaged research. They really understand the time frame we need and value of the work what we are doing. And I get huge, tremendous support from the NIS to continue my project. And that was a great support for me. Yeah.
That's good to hear. So we're coming up to the end of the hour, but I would love to hear what are your future plans or hopes and dreams for mental health programs for refugees and immigrants in the United States or in other countries? Like what if you know, what are the things that you worry about that keep you up at night, or what are the things that you're very hopeful for that we could do a better job of delivering mental health services to especially refugee and migrant communities?
Mhm. Yeah, thank you so much for the great question. For this point, I really wanted to say that instead of focusing on the mental health, if we start our program by saying stress reduction, then that is so much warm welcoming to everybody. When we start our talk by saying mental health problem, then the people, they feel like, oh my God, what is, no, I don't have problem, this and that. They feel like little bit stigmatized. If you said that, oh, this is the mental health program to reduce depression, then they say, no, I don't have depression and this program is not for me. But when we start by saying stress is so common to everybody. And I used to give my own example by saying that when I was in Nepal, I have this much of stress, right? Now I'm here, I have this much of stress. So it doesn't matter whether I have a PhD, I am professor, it doesn't matter. Stress is so common to everybody. So we really need to work to reduce our stress, because stress has a huge impact, not only on the mental health, all different type of health problem is related to the stress. And then we can easily reduce our stress. And we know best, I know best, how can I reduce my stress? So it's my job to work on how to reduce the stress, and that will be beneficial to me. The other person, they can help you based on the information you provide to them. So you know best what is your health, how you can reduce the stress. So that entry point I found is very much like empower, encouraging for all the members. Otherwise, they feel like that, oh, you don't have stress because you are educated, especially from the community members. What they think was, no, you don't have, they feel like that I don't have any stress because I'm educated, I'm working here. But that's not true. I have lots of stress. I used to do this to reduce my stress. And that is an encouraging point for the community members. Stress has no boundary. Everybody has the stress. So we really need to work together to reduce the stress, and that is beneficial not only for the mental health, for all of our health problems. We can prevent all different health problems, chronic disease, diabetes, cancer, all those things. So that is the entry point and the key message I'm delivering. And the community member, they were so much inspired on that point. Oh, no stress, I have to reduce my stress, let's do this. And once they feel better, they are so much encouraged to do more and more. And recently, the one community leader, he told me that actually this program healed our heart. That's
Oh,
the thing he
that's
told
so,
me. That
oh,
was so tough to me. And then he said, actually, this program is healing my heart, mind, and soul. And this is giving me lots of energy to not make myself healthy, even to work for the community, to for myself, and to for all the things. This is like a source of some energy and strength from inside. Yeah, that's the key thing. Yeah, and then I have so many heartwarming like feedback from the community on how much they are happy and enjoying their work. And in terms of outcome, I said those nursing students and nurse and public health and PhD, and they are like a good, I feel like they are just light in the community to bring
I think
peace.
I think that's such a great place to stop, a very hopeful place. I love that. I hope you keep that written down somewhere because those are some really powerful words. I can't thank you enough for spending time with us today. We learned so much from the work that you're doing, and I appreciate you telling us all of these great stories about your community engaged work. I've learned a lot today, and I just thank you for spending time with us and for sharing your experience with us. And I love talking about stress reduction, and we've talked for, I don't know, years about what should we call this? We don't want to call it mental health. We don't want to call it mental health. So you just answered our question for us. So thank you for that really powerful advice. I just want to thank you again and thank all of our participants and everyone who spent their time during their lunch hour watching and asking great questions. And thank you so much.
Yeah, thank you so much. It is also my great pleasure to sharing all